Hi, I'm Abby Clomer, and I'm presenting from Hastings, Nebraska. And today, Olivia Gonzalez will be joining me from Scottsbluff, Nebraska to discuss the urgency of antibiotic resistance, specifically Carbapenem-Resistant Enterobacteriaceae. So, Olivia, what can you tell us about these specific antibiotic-resistant bacteria, and what are some of their features?
Thank you so much for having me and giving me this opportunity to discuss with you today about the Carbapenem-Resistant Enterobacteriaceae, which is also abbreviated as CRE. CRE is a gram-negative rod-shaped bacterium. CRE is resistant to carbapenem. Carbapenem is a type of B-lactam, which is a family of diverse antibiotic molecules. Structurally, carbapenems are similar to penicillin but have the structure of the carbapenem ring. CRE are typically reserved for treating ESBL and AMP-C producing bacteria. The carbapenem groups in these antibiotics act to protect the beta-lactam ring from degradatory enzymes produced by the bacteria. Carbapenem antibiotics as well as penicillin degrade the bacterial cell wall at the penicillin binding protein from the beta-lactam ring. With this, the family of antibiotics prevent the synthesis of the peptoglycan layer of the bacterial cell walls. They do this by binding to the active sites of the penicillin binding proteins. The penicillin binding proteins are responsible for the final steps of peptoglycan synthesis. This prevents the cross-linking of the peptoglycan layer, preventing proper cell wall synthesis. CRE typically do not affect those who are healthy already. Infections are common in the elderly and those who are immunocompromised.
Okay, perfect, thank you. So, what antibiotic or antibiotics are these bacteria resistant to?
It's an amazing question that you asked. So, as I mentioned earlier, the Enterobacteriaceae has developed resistance to a group of antibiotics known as carbapenems. This has become known to be the Carbapenem-Resistant Enterobacteriaceae.
Okay, so could you please describe to us how the antibiotics typically kill the bacteria and how these bacteria gain resistance to the antibiotics?
I think that is an amazing question. So, antibiotic resistance occurs when the germs can no longer respond to the antibiotics that are designed to kill them. CRE are difficult to treat because they do not respond to commonly used antibiotics. The CRE are usually resistant to all available antibiotics, and this is why CRE are a threat to the public health. So, as for your second question, bacteria can have multiple resistant mechanisms to carbapenems, but the most common one is the carbapeneminases enzyme production. These enzymes destroy the antibiotics before they can act. Carbapeneminases are usually found on the mobile genetic elements such as plasmids. This motility allows for easy transfer of the resistance-inducing gene. Another less threatening resistance can be to the porn defects in a cell. Porins are important channels for the entry of antibiotics into the cell. This prevents the entrance of antibiotics, therefore the antibiotics become ineffective. Some cells are able to develop the efflux pumps. These pumps pump the antibiotics out of the cell, making it impossible for the antibiotics to act.
Okay, so how does our immune system respond to these bacteria?
Great question. Yes, the immune response does play a role in this. So the Enterobacteriaceae are a family of bacteria that can include the Klebsiella and E. coli, which are normally found in people's digestive tract, where they're supposed to be. They're completely harmless, so there's no issues there. But if the bacteria spreads out into the other intestines where they're not supposed to be, such as like the bloodstream, bladder, lungs, or skin, then it can be problematic. So CRE infections are typically transmitted when healthcare officials have direct contact with someone who is infected with someone's bodily fluids, such as like blood, drainage from a wound, urine, stool, things like that. So infections can also be spread by the touching of medical equipment or the infection on a flat surface, just coming into contact with that bacteria. Something that we still do not know is how long the bacteria can remain alive on contaminated surfaces. So that's something that researchers are still trying to figure out. Healthy people, as I've mentioned earlier, are not typically at risk of becoming infected with CRE, but those who are most likely to become infected with this disease are those who have weakened immune systems, or who stay in healthcare facilities, just because, as I mentioned a few sentences ago, because the CRE is very commonly found with healthcare equipment, things of that nature, just again coming in contact with the fluids of patients. So the spreading of these illnesses can differ, again, just depending how the disease can spread, because this can include like blood infections, wound infections, urinary tract infections, and ammonia. So these can vary, just again depends with the contact. Symptoms of this can be high fever, chills, drowsiness, swelling, redness, or soreness can be possible symptoms. It just really depends on the spread, the person, the body, just how that looks, and there's just a long list, but those are symptoms that they have found just over time, and there may be more, there may be less. They're still figuring out little details of this bacteria.
We have physical and chemical barriers of protection that need to be breached so that the immune system can activate the phagocytes, which will then activate phagocytosis. The phagocytosis will then be carried out by finding the bacteria and recognizing their PAMPs or DAMPs by using PRRs. Once the bacteria are recognized, the bacteria are pulled into the phagosome, and the phagosome fuses with the lysosome. The lysosome creates oxygen and nitrogen radicals that act to degrade bacteria into particles. If there are too many cells for the phagocytes to handle, reinforcement is signaled by the release of cytokines and chemokines. The chemokines recruit more cells, such as macrophages and neutrophils, to work to kill off the pathogens. The cytokines cause things like vasodilation, which allows cells and fluids to leave blood vessels and go into the tissue. The acquired immune system will be activated as macrophages present antigens on the MH class II receptors to T cells. The B cells recognize the antigens floating through the lymph and can be activated by binding. When the helper T cells are activated, they secrete cytokines, which helps B cells to make more and better antibodies. After activation, the B cells replicate and secrete the B cell receptors, which are also known as antibodies. The antibodies can then kill off the pathogen using neutralization, opsonization, or the complement system. The complement system itself involves killing of the pathogen using the MAC complex, activating phagocytosis, or increasing inflammation.
But Abby, my next question for you is, where are CREs problematic? In this world, are there certain places, certain locations? How can we, what makes them problematic? So is there something we can avoid, or what makes them so dangerous to where we have to be aware of them? If you can go into more detail with that, that would be awesome.
So CREs are impacting many areas of the world, and the CDC has actually tracked some carbapenem-aces. On their list, they include carbapenemase-producing Klebsiella pneumoniae, New Delhi metallo-beta-lactamase, Verona integron and Condid metallo-beta-lactamase, imipenemase, and oxacilinase 48-like. The most common carbapenemase found in the United States is carbapenemase-producing Klebsiella pneumoniae. And although carbapenemase-producing Klebsiella pneumoniae is most prevalent in the United States, there are also other carbapenemases that are more prevalent in other parts of the world. One of them that I've previously already mentioned, the New Delhi metallo-beta-lactamase, or as people call it, NDM, producing bacteria. These originated in New Delhi, hence the name, and they've also spread throughout the world. And if you look at this picture, the purple countries represent areas which are impacted more. The NDM producing bacteria are highly prevalent in these areas. And you can see that's where the bacteria originated in the first place, which makes sense. The blue countries are where there are frequent outbreaks, and the yellow countries represent places where the outbreaks are more sporadic. There's only a few cases. And the countries in yellow usually see their sporadic cases because of people who have traveled to more heavily impacted areas and stayed in a hospital or somehow contracted the bacteria. So these developing countries are seeing an increase in antibiotic-resistant bacteria because of a few different reasons. one of them being the lack of adequate transportation. So when drugs are en route to wherever they're going, they may be stored at inappropriate temperatures, which causes them to be ineffective. And of course, the people who are administering these drugs aren't aware of the ineffectiveness of them. In addition, it's very easy to get your hands on an antibiotic without a prescription in these countries. You can go pick one up at a pharmacy, a drugstore, or at a roadside stand without a prescription, so obviously this would lead to overuse of antibiotics. I've already mentioned how developing nations contribute to the rising number of antibiotic-resistant bacteria, but developed nations also contribute to these rising numbers. For example, in the United States, due to a lack of screening, antibiotics are often used to treat viral infections. In addition to this, they're used as preemptive care measures, so before someone goes into a procedure or a surgery, antibiotics may be used as a preventative measure. So why are CREs so problematic for us? Well, carbapenems are some of the strongest and broadest antibiotics out there. So they're used to treat many infections caused by multi-drug resistant bacteria. And when bacteria are able to produce carbapenemases, the treatment options left are very limited. And they're usually harsher. And as Liv said before, the people who are mainly affected by CREs are the immunocompromised, so the harsher treatment options may not even work out. In addition to this, horizontal gene transfer can occur, and when this happens, the plasmid containing the resistant gene can be transferred to an initially harmless bacteria. Lastly, this opens the door for it to be possible for bacteria to be able to express the genes from KPC and NDM-producing bacteria.
Abby, that is crazy to think about all the places that are problematic in this world involving CREs. My next question for you is, what interventions are being placed to prevent the spread of CREs?
Yeah, so there are many intervention techniques being put into place. For example, in the United States, a few include putting those who have tested positive for CREs into a specific ward or a private room, or designating specific equipment for those who have tested positive, and that's common equipment such as stethoscopes or blood pressure cuffs. And in addition to this, making sure that the healthcare workers practice proper hygiene. And then lastly, the screening of patients who may be at a higher risk for CREs, such as those who may have traveled outside of the United States and stayed overnight in a hospital there. So one study targeted at reducing the prevalence of colonization of KPC was put into place in a long-term acute care hospital, and they referred to this intervention as a bundled intervention because there were a few different methods put into place in order to prevent colonization of KPC. And the methods they put into place included the screening of patients upon admission and then bi-weekly once they were admitted, and this was done through rectal swabs. And they also put into place contact isolation and the segregation of patients who did test positive for KPC. And then in addition to this, they gave the patients daily bathing and then provided educational materials for healthcare workers. And the prevalence of KPC before the methods were implemented was gathered through semi-annual swabbing. And then after the methods were implemented, the KPC prevalence was monitored through rectal swabbing again, but this time bi-weekly. So before the bundled intervention, the KPC rectal colonization rate was 45.8%. And then immediately after the bundled intervention was put into place, the KPC rectal colonization rate dropped to 34.3%. And then following the intervention, it was down to 32%. And in addition to this, bacteremia caused by KPC was down 56%. And then lastly, bacteremia caused by any pathogen decreased by 32%.
My next and final question for you is if there's any new and promising drugs that could help fight against CREs.
So older antibiotics can be used to treat infections caused by CREs. For example, fosfomycin has an 80% success rate at treating these infections. And in addition to fosfomycin, aminoglycosides, colistin, and tigecycline can all be used to treat CRE infections. And in addition to this, you can be treated with more than one carbapenem at once, and when this is done, it's called double carbapenems. As for new and upcoming drugs that are being approved to fight infections against CREs, there are a few novel drugs that have recently been approved, and one of them is eravacycline, and this drug has a tetracycline core that has modifications to two of its carbons, which are carbon 7 and carbon 9, as you can see circled in the picture. The picture on the right shows just a regular standard tetracycline antibiotic, while the left is showing eravacycline's structure. So these modifications were done synthetically, and this drug can withstand broad spectrum resistance of some bacteria, and it works by binding to the 30S ribosome. This prevents the amino acid tRNA from being able to bind to the A site, and proteins cannot be synthesized. So in regular tetracyclines, the bacteria can become resistant when they're able to produce a protein that stabilizes the tRNA onto the ribosome despite the presence of the antibiotic. Or they can also become resistant when there's an efflux pump that pumps out the antibiotic. However, the eravacycline is not really affected by the tetracycline efflux pumps or other ribosomal protection proteins, and the drug has been shown to be strongly effective against anaerobic, aerobic, gram-positive, and gram-negative bacteria. And those it was not seen effective on include Pseudomonas aeruginosa and Burkholderia cenocephacea. In addition to this, it can be administered intravenously or orally. Thank you guys so much for listening to our discussion about Carbapenem-Resistant Enterobacteriaceae.
And we just want to thank you guys just so much for giving us this opportunity to discuss to you about the Carbapenem-Resistant Enterobacteriaceae. We hope that it could be beneficial to you and your studies in the future, and we hope you gain something from this discussion. Thank you again. Have a good day.